Sorry, just trying to get it so that I can see. I'll just share my screen. Can you see the presentation or not? I think I've shared the wrong screen.
I can just share, we can see your screen only.
Yeah. Sorry, I've got a dual screen running. It's my wife's a lawyer, so it's her computer. And it confuses me sometimes. Share screen. So that one. There we go. There we go. You guys should be able to see the presentation now.
Yes, yes, we do.
Yes, we can see it, sir.
Okay. Righto. So when it comes to trauma, most of what we deal with here is going to be blunt force trauma. Our trauma population, it's probably about 90% blunt force and then about 10% penetrating. The penetrating is usually a mix of accidental injuries, so falls with piercings and the occasional stabbing. Very rare we get gunshots here. I haven't put anything about gunshots here, and most of this is geared more towards blunt force trauma. I don't know if that's similar to the trauma populations that you guys see. Is that?
No. Mostly ours are just motor vehicle accidents and at times fall from the trees and all the stuff.
Yeah, so say the same that we see. Well, like I think when I was working on the trauma unit, like 90% of the patients were motor vehicle accidents. So someone comes in. Let's talk about a situation where you've got a 40-year-old guy. He's fit and healthy. Otherwise, he's taken a fall onto his left-hand side. He's got some pain on inspiration on that side, and he's got increasing pain and tenderness. Do you want to tell me? Do you want to start? Do you want to tell me how you go about assessing this patient?
Yeah, so good afternoon, good evening, Dr. Brett. So any trauma patient, we follow the EMST or the ATLS protocol to manage these patients. Starting off with the basic airway management, ensuring that the airway is patent. And an adjunct to this is cervical spine stabilization. And then coming to his breathing, ensuring that he has bilateral symmetric thoracic movements, equal chest expansion, looking for bruising, external lacerations, injuries, flail segments, and things of that sort. Also checking and auscultating and percussing to look for pneumothorax or hemothoraces, checking tracheal deviation, making sure that he doesn't have a tension pneumothorax. Once the B is sorted, you come to circulation, making sure he has two large IV cannulas inserted, take some bloods for X-match, and basic blood tests. If he is hemodynamically challenged, we should start resuscitating. At the same time, if he's suspected to be bleeding a lot, we should get into communication with the blood bank and secure some units of blood. And the disability is checking for his GCS, checking for his pupils, making sure he doesn't have any aspect of head injury, and also preventing him from exposing him, preventing him from hypothermia and any other chemical exposure. And then once we have primarily stabilized him, we should do our top-to-toe examination, not to miss any injuries, which is easily missed if there is distracting injuries or if the patient is obtunded or cannot respond.
I think that's good. So essentially what you're going through there is an ATLS primary survey, which is fine. The way I'd tighten that up is just to flag that at the start, say I assess this patient according to ATLS protocols or EMST protocols, starting with a primary survey, and then you start going through it. And the thing is, once you start that, the examiners don't care because they know that you're saying the right thing. So they're like, any good examiner is probably going to cut you off there and move you on to something else and talk about something more interesting. So you want to get out as much of this as quickly as possible. So you're right, airway is like making sure that patent airway, no tracheal deviation, C-spine non-tender, and in precautions if needs be, and then boom, boom, like, and when I sat exams, we had it down to about 30 seconds. We could get through the whole primary survey. But that was good. Like everything you said there was right. So you did talk about resuscitation. So you said you got to C and you said resuscitation. What are you going to resuscitate this patient with?
We usually start off with the crystalloids, either with normal saline or Hartmann's solution. However, if he's requiring multiple crystalloids, more than 3 to 4 liters, then we would start giving him some bloods to prevent hemodilution. And if he's requiring more than 4 units of blood to maintain his hemodynamic stability, you might have to initiate the massive transfusion protocol.
Okay, good. So you're going to start off with some crystalloid. Like you've got a young 40-year-old guy, let's say his heart rate's 105. How much crystalloid are you going to give him? You're going to start with like 250 ml bolus or something different than that?
So 105, so he is tachycardic, and for a young fit guy, the first sign of some sort of hypovolemia, fluid loss is tachycardia. So yeah. I would give him something like a 500 mils to 1 liter fluid, but everything that I do will be monitored, and I would see his hemodynamic status by measuring his urine output and seeing his vital signs change. So if I do give him a bolus, I would want to see his tachycardia come down, and therefore I would be ensured that we are doing adequate resuscitation. Or if he starts making urine output, preferably more than 0.5 mils per kg per hour, then I would be at ease that we are doing adequate resuscitation for this patient. Yeah, so any boluses I give has to be monitored. There's no particular amount of bolus that is like
I think
like everything is measured.
You're right. Like you need to always assess it. In a trauma scenario, I'd just say I'd give a liter, and particularly a young, fit, healthy guy, just say I'll give a liter bolus stat and then reassess the response to that. And you're right. You do want to monitor. You do want to monitor how the patient responds. Urine output's a good way of monitoring response to fluids. However, in a true severe trauma situation, you're not going to be monitoring mils per kilo per hour, because like the patient could be dead in an hour. So you're giving stat doses, your heart rate, and going from there. Going forward, yes, definitely. If this patient's going to theatre and on the wards for a few days, you will be monitoring their urine output. That's good. Just before sitting or having your vivas, I'd just think about what kind of answers you're going to give to that. And like with that, I'd just say, yeah, a liter crystalloid stat. Okay, we'll move on to someone else. Maybe someone who's not sitting exams. Do they want to tell me what what they think about crystalloid versus blood for potential blood loss and fluid resuscitation? I'll just start picking people if nobody's going to chime in. I'm just going to go down the list of what I can see. Neelam? Maybe not. Okay, Basharat?
Dr. Basharat is one of our consultants. In the
Okay,
school.
apologies. Well, Pani, do you want to, it sounds like the junior guys are a bit reluctant to answer. Do you want to, what's your feelings on crystalloid versus blood in major trauma?
So for major trauma, I would still resuscitate with crystalloid. There's been studies that they show that there's not the replenishment of the volume loss is somewhat similar to what you do with the blood, but the availability of blood is the issue. So I would still go with crystalloid unless and until then I really know that what I'm going to infuse this patient. So crystalloid is still the way to go for me.
I think that's a good answer. Like, people are going to have different opinions on that. In practice, even working in a major trauma center, they're going to get crystalloid first, just because even if we activate the massive transfusion protocol prior to the patient getting there, the ambulance staff are going to start running in crystalloid before we get the patient. So they almost always get crystalloid before we do. We get them. When it comes to if someone hits one of our trauma bays and we know that this person's bleeding and losing a lot of blood, that's when we start transfusing blood products straight away. And do you know why we stop the crystalloid and start straight with blood? Does anyone know? The reason for Jose?
Yeah, Prof. So the first for resuscitation is, of course, it's crystalloid. Once that if depend on the patient respond, transfusion respond or unresponding. If the patient is resuscitated with the crystalloid, if they still unresponsive, I activated massive blood transfusion. I can continue with the crystalloid because of this patient lost most of the blood. So if I continue that crystalloid, the patient might develop the coagulopathy. So I have to transfuse blood so to avoid that coagulopathy for this patient.
Exactly. That's what we get worried about, is coagulopathy. Does anyone know the ratio of blood products that you give in a trauma scenario? Do you just give red cells or do you give something else?
So it's I think 1:1:1. So
yeah.
Red cells, FFP, and platelet.
Exactly. So you want to reapproximate whole blood, and that's the way you give it 1:1:1. Okay, that's all good. We'll move on to some stuff that's a bit more dry now. So when it comes to blunt abdominal trauma, such as this guy who's had a fall onto his left-hand side, he's when it comes to the pathophysiology, there are there's two major ones. There's sharp, then there's blunt, and in blunt there's crushing or shearing. So crushing is when you've got an external compression force that leads to a burst injury of the organs in question, and then shearing is when you've got sudden deceleration, and that's like a motor vehicle that's hitting a wall or a tree or something like that. And the areas that are at risk there are the ligamentous attachments of those organs, which remain fixed as the organ keeps moving. And then you've got secondarily penetrating, so bony fragments penetrating other organs. Now, for left-hand side, difficulty breathing and increasing abdominal pain, what's the thing that first comes to mind? Neil?
So yes, fall on the left-hand side, difficulty breathing and trauma. So I would be worried about chest and abdominal injuries. So the abdominal injury I would be worried about most is splenic trauma, which is one of the most common abdominal organ, solid organ injuries. And the chest injuries I would be worried about is if he does have rib fractures, whether he has a pneumothorax or a hemothorax, which is collecting, that we need to sort out. Yeah.
Good. Which of those ones you've talked about is the most critical? You've already answered this very well already, but so it's just going back to first principles. Which one's the most critical?
So yeah, when you look at ATLS protocol, you need to sort out the breathing first.
Good.
So
so exclude a chest injury and then worry about what's going on in the abdomen. And yeah, you're right. The thing that you worry about in that situation is going to be a splenic injury. So this probably doesn't project all that well. Jose, do you want to, this is a single slice axial CT of a patient of a similar scenario. Do you want to tell me what the obvious abnormality is on this CT?
Okay, in the CT, that axial view of that CT abdomen. So what I appreciate here is there's some abnormalities in the. There is some free fluid collection in the left side on the left upper quadrant, which is also that's seen that most likely a splenic injury.
Good. What would you call that? So I agree, it's a splenic injury. And there's two things going on with this spleen. Do you know? Can you tell what they are from this?
I'd like to have a go at that. I think I can see is this definite subcapsular hematoma with I think those white lesions are the contrast blush that is going on. So that's active bleeding still going on in the spleen with the hematoma formation.
Good. So you've got a hematoma and you've got active blush, both of which are very abnormal. This is a spleen that's going to need something done about it. I think that we already went through all this, that splenic trauma is one of the most commonly injured intra-abdominal organs. It's not commonly injured by penetrating trauma because the 9th to the 11th ribs protect the spleen. However, it's very commonly injured in blunt force trauma, particularly if you've got rib fractures. The last part's probably more relevant to colorectal surgery. Does anyone know any grading systems that you'd use to grade splenic trauma?
Yeah, so the grading system is grade 1 to 5. So it's laceration and trauma. So laceration less than 1 centimeter with a subcapsular hematoma less than 10% of the spleen is grade 1. Then laceration 1 to 3 centimeters is or the capsular hematoma from 10 to 50% is grade 2. Anything laceration more than 3% or subcapsular hematoma more than 50% is grade 3 without any devascularization of the spleen. And then grade 4 is approximately less than 25% devascularization of the spleen. And grade 5 is a shattered spleen, which is major splenic injury and devascularization.
Good, really good. So I think that's completely right. Yeah, I can't say anything else to add to that. Righto. And we went through this at the start. So the management of splenic trauma is the same as any trauma. You do your primary survey first. Chest X-ray is particularly important in this situation. Look for left-sided rib fractures. A pelvic X-ray may or may not add much to this, but it's something that would often be done fairly routinely. Do you guys do much in the way of abdominal fast scans?
Yes.
So when I say, like, I'll put this statement here saying utility is probably more so for transient responders and unstable patients, and it's less useful for us in stable patients. Anyone in this situation at the trauma center where I was working was getting a CT scan. So the only time, like, everyone would get one, but the only really changed management in those people that we were deciding on whether or not we had to bypass CT. And then there's a secondary survey, which Ravnil mentioned. So look for a seatbelt sign or a Kerr sign. So left shoulder pain, worse on inspiration. So when it comes to management of splenic trauma, the way we would manage it is if they're stable or transiently responding enough, what we do is get a CT pan scan. So like you want IV contrast, so you can look to see if there's contrast extravasation like there was in the gentleman a few slides earlier. And you want to see if there's a hematoma, and that allows you to grade the splenic trauma. If the patient's unstable and they're EFAS positive, then they get a trauma laparotomy. If the FAST scan was negative, then we need to consider, have we missed something else? Is there another source of bleeding that we've missed? Oh, probably should ask you guys that. Okay, Pani, how do you manage splenic trauma? And you might have seen the slide ahead. So break it down by grade, what you do.
So for splenic trauma management, once we have assessed the patient and we have come to this a stable transient patient, so grading wise, I would manage. So the types of management is conservative management, active surveillance. You can do angioembolization, or you can go for surgery. So these are the 3 steps for management of splenic trauma. So if the patient is stable, hemodynamically stable, and has a grade injury from 1 to 3, I would like to watch the patient and assess the patient as time goes by. Keep the patient in on bed rest, monitor vitals, monitor the HB daily, and monitor the urine output just to see. So here we are, we've already seen the CT scan. We are treating the patient here rather than the imaging that we have seen. So I'll manage the patient conservatively unless and until the patient is hemodynamically unstable. Then I'll go in for trauma laparotomy.
Okay, and say if you've got a patient who you do a scan, they've got a grade 2 splenic laceration. Are there any contraindications to managing that patient with conservative management and observation on the ward?
On top of my head, I can think of portal hypertension. Portal hypertension could be, if the patient is a known case of portal hypertension or liver cirrhosis. These patients with splenic injury have a high venous pressure. So these patients would not be able to form a clot and would continue to bleed. So that's, and anybody with coagulopathy.
Yeah. So anyone who's coagulopathic, that might push you more towards interventional management. Just in general, is there any other class of patients that you might not do this for?
So this patient has a contrast blush. So usually a contrast blush, you wouldn't want to manage conservatively, as there is active extravasation of fluid.
That's good. Like if they've got a contrast blush, that's another situation that will push you into active management. Anything else? There's something I'm thinking of, which if I had a patient who had a grade 2 splenic laceration, a bit of free fluid, no active contrast blush on a CT, but I'd be like, no, like I'm not 100% sure about this one, of sticking them up on the ward.
Is it an immunocompromised patient that I'd be worried about?
In a what, sorry?
Immunocompromised.
Immunocompromised. Not so much. I'm also thinking, like, if you've got someone who you can't reliably assess their abdomen. So if you've got someone who's like really drunk or drug affected, you might not be able to get a reasonable examination out of them. So you might be pushed more towards doing something. Also, if you've got someone who may have a mental handicap, that might sway you towards doing something more interventional. So that's good. So that's grades 1 to 3. What about the other grades?
So for I have managed. We have actually managed a grade 4 splenic injury patient just 2 weeks ago, and apparently we managed that patient conservatively, and he did well in the ward. So again, for grade 4 and grade 5, grade 4, I would still watch the patient and see how the patient is doing in the ward, and for grade 5, definitely I would resuscitate the patient well, because grade 5 is a shattered spleen. I mean, keeping the shattered spleen is just another source of infection. And so I would plan my operation and resuscitate the patient properly before taking the patient in, because since the patient is a responder, so I would plan it and then take the patient in for a splenectomy.
Okay, that's good. And I think that's all right. Like and what you're saying there is you manage the patient, you don't manage the imaging. I think that's true. And you will have some grade 4 splenic injuries that you can manage non-interventionally. You'll have some grade 3s or maybe even grade 2s that you need to take to theatre. What we do, we've got, well, where I trained, we have really, really good access to interventional radiology. So most people who had grade 3, grade 4, even if they didn't necessarily have a blush, like definitely with grade 4, even if they didn't have a blush, they would get embolization just as a prophylactic measure. And we'll get to why they get that down the track. But you mentioned grade 5 and the fun bit about trauma surgery. So which one of you guys wants to take a crack at describing how you're going to do a trauma splenectomy? Go for it, Pani.
So trauma splenectomy, my patient, I would prepare the patient pre-op. So pre-op will be all the getting the patient in with IV cannulation. The anesthetic team would be ready. I'd assign a bed in ICU post-op for this patient. I would get my prophylactic antibiotics given, and mechanical DVD prophylaxis if for this patient, if this is a big patient. I will take the patient in theater. In theater, we would do a timeout. We would ensure that there's blood products available for us. And once my team and my team has been confirmed, I would prep the patient in supine position. My approach will be a midline laparotomy from the xiphisternum down up till the umbilicus. I would not go for a transverse or chevron incision because I want my incision to be expansile, and I want to see all the organs in the abdominal cavity as well. So just dissecting layer by layer, skin, subcutaneous tissue, fascia. As soon as I reach the linea alba, I would let the anesthetic team know that they can expect a drop in BP as soon as I release this tamponade that is being formed by this abdominal wall. And hence I will enter the abdominal cavity, and I will start to peck the abdominal cavity with the place where I can see bleed oozing from or coming from first. So I'll peck all 4 quadrants with large laparotomy pecks, and then I will see which one gets soaked first. So I will then let my anesthetic catch up with this patient, and then I will start removing the pecks from the place where there's the least soakage or the least chances of bleeding. And once I get to do that, I'll ensure that all the other quadrants are safe enough for me to remove the pecs, so that I can mobilize the organs to those quadrants. And then I will slowly and gently remove the pec from the spleen. And so to prevent bleeding from the spleen, one of the things I could do is hold the splenic vessels at the splenic hyla, and then remove the pecs. And from there onwards, I would then mobilize the spleen from all its attachments. So initially, I'll start from lateral to medial, while getting control of the vessels in the hyla already. So I would first ligate the splenorenal and the splenophrenic ligaments and mobilize the spleen medially. Then I would go and suture ligate the gastrosplenic ligament, where I will take hold of the short gastric vessels in this in that ligament. And I usually, in Suva, we had a harmonic scalpel which we used for this, but otherwise I would ensure that I suture ligate these vessels, because these vessels tend to be very notorious for bleeds, and once, especially when there's gastric distension, this can actually pull off the sutures that are just looped around the vessels. So I'll suture ligate this, and take care that I do not take the body of the stomach in this suture ligation as well. And lastly, I would ligate the splenocolic ligament and deliver the spleen medially into the in the middle of my wound, and then ligate the vessels, the artery first, the vein, and then the spleen out.
Excellent. That's good. I think that's exactly right. And that's the perfect textbook description of how to do that. Ravneil, have you done an operation for a shattered spleen before?
Not for a shattered spleen, Vinoy. But
have you, Pani?
I've assisted in a few, not done one.
Like, was that how it was done when you were assisting?
Most of them were so fast that I couldn't even catch up what was happening. But
so the way it ends up happening in practice is, at least in my experience, I've done a few of these, is that the only spleens we're taking to theatre are ones that are truly shattered, and you release that tamponade and the patient starts crashing. And so you're just scooping chunks of spleen out from the left upper quadrant and looking for the splenic hilum, which is usually just free floating. And then you're just trying to get a clamp across that, and then a clamp across the gastrosplenic ligament, like you said. So we didn't get asked this in our exam, but we got asked it a lot during practice, and we'd all say, yeah, like that's how you do it according to the textbook. But in practice, it's just like, it's like you said, it's like everything's happening so fast, and you're just trying to scoop out the shattered spleen and get the bleeding points. What are you worried about when you take the splenic hilum? What organ is at risk?
The tail of the pancreas.
Yeah. And then when it comes to harmonics, like different people say different things. Like I think it's just easier to say you're just going to suture ligate, because some people say, oh, you shouldn't use a harmonic during a trauma scenario and all that. I think if you've got it, it's a useful tool, and like I personally would use it. But some people, particularly people who didn't train in the time of having a harmonic, would say that you shouldn't use it. That's good. That's I think that's exactly right for how to do a trauma splenectomy. I think that we've gone through everything here. You guys answered all this stuff really well. so repeat imaging, we used to talk about whether or not we'd like rescan the patient. They did a study of 85 of American trauma surgeons, and 85% of them said they wouldn't re-image to see if there was delayed bleed, because that's not going to change your management. You're going to treat the patient, not scan. So if they have a significant delayed bleed, you're going to see that clinically, and if they don't, they'll be fine. And if you've got someone who's fine and then they've got a small increase in their splenic hematoma, you're like, well, what does that mean? Like what does that mean for this patient? Should I take their spleen out? They're fine. Like, when did they have that small increase in bleed, in the hematoma? And on that, like delayed rupture, that can occur anywhere up to 2 weeks. They tend to happen earlier. Like I've seen a couple happen around day 3, day 4. I haven't seen any happen out of 2 weeks though. Just a bit of on embolization. Do you guys have much in the way of embolization?
No.
Yeah, it's like even in Australia, you need to be in a reasonably big centre to have access to embolization. Like I've worked in a lot of hospitals here where you don't have anyone who can do this kind of stuff. So you're doing a splenectomy if they need something. But in a big trauma centre, it is useful. You take someone who's going to get a laparotomy and they just get a small groin puncture and they keep their spleen. And even though you embolize it, they do retain some degree of splenic function. And this is just like, it was, yeah, like grade 3, grade 4 injuries were the injuries that we would tend to embolize here. And that's just because the 1s, 2s, and some of the 3s are going to be managed on the ward. The grade 5s, they clearly need to go to theatre. And then the grade 3, 4s, these are the ones where they would have likely gone to theatre, and we can kind of prevent that by just doing embolization. Yeah, I think you said all this really well. Okay, yeah. Right, Neil, you want to tell me about salvaging the spleen? So salvage surgery for splenic trauma.
So there's 2 modalities that I have read about, Dr. Brad. Haven't assisted or done any. Most of the times we have done splenectomy rather than the splenic salvage. One of them is just a splenography. So from my understanding, if it's just a small incisional wound or laceration that is that we can suture and stop bleeding and possibly put a omental patch on it, and that controls the bleeding. So we have essentially salvaged the spleen. The other modality is a partial splenectomy. This is on the basis that the splenic artery gives segmental arteries. So the spleen is divided into vascular units or segments. So if a particular splenic segment has an isolated injury, which we can do a partial splenectomy for, that is done. But I've never seen any of these 2 procedures done.
Yeah, I'd agree with that. In a trauma setting, I haven't seen either of those done as well. And I think that this is from Top Knife, the trauma book, that the best way to preserve the spleen is in formalin. Like if you're doing a trauma laparotomy and the spleen is the primary injured organ, then it probably needs to come out. And like it's just risky to try and salvage it in that situation. There are situations where you might consider it. So like if you were in there, someone had like a perforated bowel or something like that, and that was the primary reason you were going to theatre, and you saw a small grade 1, grade 2 injury, like a laceration that you thought you could suture, it might be worth doing something about that at that time. Like I've never seen that, because like in a trauma centre, that patient ends up getting their abdomen packed and either going to hybrid theatre or back down to the interventionalist to embolize the spleen if it's a problem. But there is a scenario, I think, where you're doing a trauma laparotomy for another reason, and then you could maybe look at doing either a partial splenectomy or a splenography on the spleen, but it's uncommon. Okay, and that's just what that's saying there. And about the only difference is, instead of a mental patch, we'd probably patch down some hemostatic material, but and a mental patch would work just fine as well. And that's just my walkthrough on how to do a trauma splenectomy, which, Punit, I think you said all that really well. Sorry, it's been a while since I've looked at this. So I think we've. Yeah, I don't know if anyone's ever seen this. I've seen some surgeons do it when they're doing like a distal pancreatectomy. I've never seen anyone do it for trauma, but they want to preserve splenic function. So you essentially create a splenunculus by taking some of the splenic tissue and then suturing it into the omentum. And the theory is that it recruits a blood supply, and then they've got remnant splenic function. To be honest, I've only seen it once, and that was in an elective scenario. I don't know if you guys have seen anything along those lines. I probably wouldn't mention it, but if anyone asks about it, like, you can do it, but it's probably best not doing trauma. So this is just a bit about loss of splenic function following splenic trauma. If you do a splenectomy, obviously they lose their splenic function unless they've got an unidentified splenunculus. If you embolize the spleen, they do retain some splenic function, and it depends on the degree of embolization. If you embolize the main splenic artery, then obviously they're going to lose more function. However, even someone in that situation, if they haven't embolized the short gastrics, which would be really hard to do anyway, then they're going to retain some degree of splenic function. What would you do for, Punit, what would you do for someone who'd had a trauma splenectomy as they're going home? What do they need?
So our practice here, Dr. Brad, is that we already have counseled the family beforehand, taking the patient in for the trauma splenectomy, that the patient will lose his spleen. After the operation, we do counsel the patient and the family about OPSI, overwhelming post-splenectomy infections, and what they are and what they need to know about it. So before sending them, within the first 2 weeks, we try to get them vaccination. And these are vaccinations are the pneumococcal, meningococcal, and the HIV vaccination. So the encapsulated organisms that we give here. And we tell them, we don't have the splenectomy band here, but we do tell them, and we document in the folder, that the patient does not have a spleen. And we advise the family, any small cold or upper respiratory tract infection or anything of that sort, patient needs to come and get their antibiotics. And we also send them home with prophylactic broad spectrum antibiotics to keep with them. So if they do develop some kind of infection, they can start on that antibiotic straight away.
What's the broad spectrum prophylactic antibiotic you give?
We usually give them Augmentin.
Yeah. So I think we give amoxicillin 250 milligrams daily as a prophylaxis, and then the emergency dose is 2 grams orally, and they're told to present to hospital for broad spectrum intravenous antibiotics. And the immunizations are all correct. The spleen registry, like, we do that. Like, to be honest, I think it's more of a research and patient liaison thing here. Like, it doesn't affect our practice. It's just something that we do. Have you seen any cases of OPSI?
I've not seen any.
Like, I've only seen one in 10 years, and the patient, they died of neck fash within a period of about 24 hours. Like, it was just remarkable how quickly they deteriorated. Okay, so I'm not sure. So, Pani, you had a crack at the last CT. Ravneil, do you want to tell me a bit about that CT?
Sure, sir. So this in this axial CT, axial cut, you can see the liver, the right lobe of the liver. You can see areas of hematoma, thin area of free fluid just around the liver, most likely a hematoma. And within the liver parenchyma, you can see some devascularization there. So this is involving less than
You're talking about this
50%.
stuff here.
Yeah.
Yeah.
And so this is involving less than 50%. So it's probably a grade 2 liver injury.
Like, I'm not 100% sure which one it is, but you're probably right based on that. So liver's obviously larger, less protected, more susceptible, but the management's going to be the same. So Parnit, I think it's your turn to go through like a trauma assessment primary survey. Do you want to go through that?
Yes, Dr. Brent. So again, my patient management would be according to the ATLS guidelines, A, B, C, D is the primary surveys. So airway, in this trauma patient, I would get the patient oxygen and C-spine, C-collar in. Breathing, we'd get the patient oxygen, put a saturation probe on, and ensure the patient is saturating well. In C, I would get 2 large IV bore cannulas, give a liter of bolus, and put in an IDC to assess the urine output and give fluids as required, and monitor the BPs. And in D is the GCS. I will see the patient's GCS as well as the blood sugar level if this patient is not having hypoglycemia. And in the E, I would see exposure, so any deformed limbs or any open wound that is oozing blood. So deformed limbs, meaning that associated with liver injury, there's other fractures like pelvic fractures that if not put straight or not binded or not anatomically reduced can also cause further bleeding. So that's my exposure part. And after that, I would then assess the patient again, going back again to A, B, C, Ds to see everything is secure. Then I'd move to the ample assessment that we do. The just a brief assessment from the family, the allergies, medication history, past medical history, last meal, and what were the events around what has happened. While doing that, I would still keep an eye on for my primary survey, A, B, C, Ds, just looking at them if they are still in normal parameters. If not, then this patient is definitely a non-responder. I would initiate a trauma, a massive transfusion protocol if the patient is a non-responder hemodynamically, meaning he's not producing any urine, and we have loaded up him in at least 2 liters of fluid in the past hour and he's not responding, still tachycardic. So from there onwards, my plan would be to take the patient to OT to stop the tap that is most probably open inside the abdomen.
Okay. I'm just going to throw out random questions that come into my head. Is there any time you wouldn't put a catheter in during a trauma scenario?
Yes, so usually I won't put if there's a associated pelvic trauma. The 3 things that we watch for in ureteral injury is blood at the meatus, bogey perineum, and a high riding prostate on a distal rectal examination. So, but the first thing is blood at the ureteral meatus and a deformed pelvis. I won't try to put IDC in.
Yeah, good. Say you've got a patient who has a pelvic injury, like different patient, they're stable, they've got a pelvic injury, they've got some blood at the meatus, but they've got a full bladder. What are you going to do with that patient?
Usually in ED, I have the ultrasound scan that is quite accessible to me, and I'm well versed in using ultrasound scan in bladder scans, liver scans, renal scans. So I would just do a needle decompression of the bladder with a cannula, 18 gauge or a 16 gauge cannula with the plastic part of the cannula still staying inside, and put a draining bag there.
Yeah, good. Like I think that's a good answer to that. If you've got if there is some question as to whether there's a urethral injury and you've got a cystoscope, you can do a cystoscope at the bedside. It depends on whether you've got access to that, and like even if you do, so like it can be difficult to do. The other, is there one other thing you could do to assess whether or not there's urethral injury?
The other assessment would be if the patient is actually passing urine. If the patient is passing urine, then there's definitely not a urethral injury.
Is there any imaging you could do?
Maybe a retrograde urethrogram.
Yeah, good. Do you know how to do that?
In our center, the fluoroscopy and the getting the patient to that X-ray department with the dye that is usually out of stock, I wouldn't.
Okay. Like we have the same issue. Like fluoroscopy is like hard to get, but I have done it at the bedside before, where you just stick a catheter into the very tip of the penis. Like, I mean, like let's just say it's a male, into the very tip of the penis. You blow up the balloon to like 2 or 3 mils, and then you just get like we've got portable X-ray guys that will come around, like if you beg them to, and they and you can just shoot some contrast up while getting them to take a series of X-rays, and you can see if the contrast goes into the bladder and doesn't extravasate. But I think I've only done that twice. It's yeah, it's not common to need to do that. Okay, that was a good resuscitation. I think that's the same information. Okay. Ravneil answered previously. I wasn't sure you're still there, Jose. Do you want to have a crack at the grading for liver trauma?
Pardon? Sorry.
Do you want to tell me about the grading system for liver trauma?
Yes, for liver trauma, it's grade 1. It's a scapular hematoma, which is a laceration of the parenchyma is less than 1 centimeter. In the grade 2 is that the subscapular hematoma is 10 to 50%, and laceration is 1 to 3 centimeter. And grade 3 is a hematoma more than 50%, and grade 4 and 75%, and grade 5 is more than 75% subcapsular hematoma.
Okay, and I think in the most recent one, they've taken out grade 6, which was complete hepatic avulsion, which it was very rare to see those patients in hospital. They tended to bleed out before presentation. Grade 5 also includes a major vessel injury behind the liver, which I have seen a couple of times, and that's a bloody scary situation. Essentially, you manage them the same. So, like, you try to manage these non-operatively, and you observe them in a setting where you've got lots of nursing staff around, and with serial hemoglobins. And once you're comfortable with it and they're not continuing to bleed, you can start feeding them. Embolization, which is probably not all that relevant for you, but it's essentially the same as with spleens. Like the grade 3 and 4 injuries with contrast, extravasation, we would lean towards embolization for those, but they do commonly get biolomas, and they're up to 20. It's probably more than that we see with biolomas. Righto, I think we've gone through. Like, I don't want to keep you guys too late, so I'll go through some of this stuff faster. So the trauma laparotomy would be the same setup that you do for your splenic trauma. You're probably going to open the whole abdomen further below the umbilicus. Depends a bit on where their umbilicus is. Sorry.
Dr. Brett,
Yeah.
if it'd be grateful if you could go more in depth in this, because I have not dealt with a hepatic trauma.
Okay, we'll talk about a bit about it. This is probably the more relevant stuff. So like everything else is just set up. So all your setups the same. But then the principles of managing hepatic trauma are packing essentially. So you want to pack the liver, and you want to, I've seen some silly things done with hepatic packing. So people putting packs into the laceration, which isn't going to solve the problem. What you want to do is reoppose the liver, so push it back together and then pack around it to keep all that together. And you will get a bit of oozing and bleeding into the laceration, but then that will coagulate, and you just leave the packs. And you give that 10 minutes, and then you can start removing your packing and seeing where you're at. And if you're in a situation where you can control the bleeding with packs, but as soon as you take the packs out, you start getting bleeding again. What we would do in that situation is we'd put a laparostomy on and come back later on. And depending on where you are, there's different forms of laparostomy. Some people just use the IV bag that they put underneath it. In the trauma centers, we've got the fancy vacuum dressings, which are nice, but I mean, they essentially do the same thing. But yeah, it's just about that reopposing the liver parenchyma and then packing around. So you want to get packs above the liver, below the liver, and then towards the side, and just push it all back towards the center. Same slide. When it comes to other things that are involved in hepatic trauma, like suturing, so diathermy, if it's like a small capsular tear, just like if you're doing a cholecystectomy or something, you tear a bit of the capsule, yeah, that might work, but it's not going to help for major bleeding. Suturing the capsule, once again, it's only for superficial injuries. And then you start getting into the stuff here that we would be calling for a liver specialist to come and help out with this. So ligating major vessels. We don't really do argon plasma coagulation for it. And if we've got just like a raw area, we will attempt things like flow seal, so liquid anticoagulants and pressure. Then you can start doing, that's a good one actually. Who did, okay, Neil, do you want to tell me how you perform a Pringle maneuver?
Sure, sir. So a Pringle maneuver is whereby you would initially start off with your digit. You would put your digit in the foramen of Winslow, the dimensions of which is anteriorly it's the hepatoduodenal ligament, which carries the blood supply to the liver. Inferiorly you have the duodenum, posteriorly you have the inferior vena cava, and superiorly you have the caudate lobe. So what you would initially do is just press that hepatoduodenal ligament, and that would eventually stop the bleeding. You can either keep on doing that with your digit, or if you have some vascular clamps available, you can temporarily use them, or if you have a Vesey loop available, you can use that to control the bleeding to the liver.
Anything else you could use if you don't have any of those? You can use a soft belt clamp if you need to. But yeah, like it's usually just easy enough to get a vessel loop and you loop it around. There are different ways of doing it. Some people pass it, they cut a segment of chest tube, they pass the vessel loop or a nylon tape through around the porter and then through the chest tube, and then you can sequentially tighten that and put a clamp on this side. So the pressure from the chest tube pushes it down, occludes it, and then you can release that. The other way, I mean, you can just, like you said, you can just clamp it and take the clamp off as well. That's good. That's good. So where that was going to is you can get a Pringle maneuver on. If that controls your bleeding, then you could do a selective arterial Pringle and set, or it's not a Pringle, but like occlude them selectively and see like which one you're going for, or you'd be able to tell usually, like if it's in the right liver, just find the right hepatic artery and then you can tie that off. You guys know what percentage of blood flow comes from the hepatic arteries versus the portal venous system?
So 80 from the venous system, 20 from the hepatic artery. Yeah,
so you can tie off the artery and they will usually maintain their liver function. I've seen a number of cases where that's worked. I have seen a case, I have seen a case, unfortunately, where we had a young guy, like I think he was 18, and they, the only way they could get control, this was embolization, they embolized his hepatic artery proper, and he ended up dying from liver failure, unfortunately. So, I mean, it doesn't always work, and it kind of depends on the degree of underlying liver damage. And then we go into liver resection. So yep.
Sorry, Dr. Brad. So the Pringle's maneuver,
yep.
How long do we keep it clamped for?
It's going to depend. So if you're doing some kind of elective surgery, you wouldn't keep it on for more than like everyone's different, but like usually it'd be like 20 minutes and then take it off and give it give the liver a flush. But if you're in a trauma situation and you've got major bleeding whenever you take it off, you just need to make a judgment call. But if someone asked me in an exam what I would do, I just say that, like electively, we're going to like cap it at 20 minutes, but we're in a trauma situation. We need to balance the bleeding that we've got versus perfusing the liver. Then we've got liver resections, which you break down into anatomical versus non-anatomical liver resections. With blunt force liver trauma, it tends to be multi-segmental. So, and particularly on the right side, they'll take out multiple segments. So doing anatomical resections, whilst it's much nicer, cleaner, less likely to bleed, often you'd be taking out multiple segments if you were doing that to control the bleeding. And it's quite rare to do anatomical resections. Debriding areas back to, I guess, something that's much easier to control is a possibility. I haven't seen much of that either. It's rare we would manage liver trauma that way. I don't know if you guys have seen much liver trauma. And then there's the really high-end stuff, which these patients are, to be honest, probably going to die. So the juxtahepatic injuries, so we're talking about injuries to the IVC behind the liver, to the hepatic veins. The first principle is to, you put pressure on it, so you push down on the liver back into the spinal column, try to get some semblance of control. If you read a book like Top Knife, which is a really good book to read for trauma, they talk about doing these shunts, so like veno-venous and arteriocaval shunting. Like I've never seen that stuff done. I think a lot of that's just stuff that they've tried in the past and nobody does these days because it's just got such poor outcomes. But if you were in that situation, you had someone that you thought you might be able to save, I guess you just got to try and get some kind of control and then mobilize the liver enough to get behind it and repair the venous injury. But like repairing venous injuries, even when you've got good exposure, is difficult, let alone behind the liver. And then liver transplantation isn't really a practical solution. The problem that patients have in this situation is that they, like if they're developing liver failure from their liver injuries, they've probably got a lot of other injuries as well, which makes them just generally too unwell to receive a liver transplant, even if you do have access. And like I said, working in a trauma center, we had a situation where we had an 18-year-old who was developing fulminant liver failure from the trauma, yet we weren't able to get a transplant for them. So it's not really a practical solution. Complications, so bioloma, so leaking bile collection, very common. If you're doing a procedure and you're packing the liver and you see a bile leak, you should try to control it. However, given we tend to manage a lot of these conservatively, then often you'll see them down the track, and you just manage it symptomatically. Like often they'll resolve or settle down. Sometimes they will need some kind of drainage though. Surveillance, like after a major liver injury, you realistically just treating the patient on their merits is probably the way to go. So if you see them 4 weeks after liver injury and they're all fine, then you probably don't need to do anything else. There's a bit of debate amongst the liver surgeons here as to what to do. I think we're erring on the side of caution and just getting an ultrasound just to make sure that there's not a bioloma. But like, well, I've picked up a few, and then you speak to the liver surgeons and you're like, well, what do you want to do about it? And they don't even know what they want to do about it because the patient's well. So it's probably an unnecessary test. Okay, this stuff, there's not too much left here. This stuff's fairly uncommon, and we probably see, of the serious injuries, maybe 1 or 2 a year, like serious pancreatic or duodenal injuries. The less serious ones, they're not that uncommon. So like a mild lipase rise after a car accident is reasonably common, or like a duodenal hematoma. But the truly big injuries, very uncommon. And they're most commonly associated with wearing a seatbelt, motor vehicle accident, and then the seatbelt cutting in and getting that, that's what am I trying to, extension flexion injury of the upper spine at the thoracolumbar junction, and then a chance fracture. Management is the same for these. This is just a picture of one we had where you can see like across the neck of the pancreas, there's this injury to the pancreas itself. Probably doesn't display all that well. I put that photo there because there was an interesting solution to this that I'll get to later. When it comes to pancreatic injury grading, essentially it's just like, is it severe or not? And then is it to the left or the right of the SMA? So if it's to the left of the SMA, i.e. in the distal pancreas, it's less severe. If it's to the right, so in the head of the pancreas, then it's more severe. And grade 5, like I've seen a grade 4, I've never seen a grade 5. And then the duodenum, it's pretty self-explanatory once you read that, and it's a lot to remember, but essentially it's just like, is this in D2? And if it is in D2, does it involve the sphincter complex. That's the critical thing with these. So duodenal injuries, if there's no perforation, just manage it non-operatively, unless you're worried about concurrent pancreatic injuries. We always try to get them fed early. So once we're comfortable that they don't have a microperforation that's been missed, start feeding on them. Sometimes with the hematomas in particular, it can occlude the lumen. It can be hard to get enteral nutrition in. If you've got someone who's really good with a gastroscope, they might be able to get a nasojejunal tube past it. But other than that, you might need to think about other ways of feeding the patient until that settles down, because it's going to take a few weeks to go down. And high-grade injuries obviously need to operate on those. Let's say you've got an injury to like D3, like how are you guys going to manage that? Let's say it's a laceration of D3 less than 50%.
I can think of two things, Dr. Brett.
Mm-hmm.
I have not been part of any duodenal trauma surgeries. I've just come across my seniors talking about it. One of the things they've talked about is the pyloric exclusion surgery. So for duodenal trauma, you just in pyloric exclusion, you just try to prevent any gastric contents emptying into the duodenum to let the duodenum heal on its own. And so you just do a bypass from the stomach to the jejunum, and you close off the pylorus. This is the theoretical knowledge that I have on this. The other thing I read about is bringing the duodenum out as a duodenostomy and letting it heal from outside in, and bypassing it there as well.
Yeah, you can do that. I don't think there's any real consensus as to what you do. If there was a D3 injury that I'd seen that had less than 50%, I'd probably just try to close the injury and then patch it if you could. So like you do for like a D1 ulcer, you do a similar thing for like a D3 injury. What have I said about, yeah, so with pyloric exclusion, like a lot of people talk about it. I don't know if there's any data that supports doing it. The other way, you can just do a complete like bypass, just go straight to a Roux-en-Y if you're not going to do something like a pyloric exclusion. With something like a Roux-en-Y, it's tricky because if you've got an unwell patient, you really want to be doing a Roux-en-Y where you've got 2 bowel anastomoses in there, rather than just doing something like a gastrojejunectomy and a pyloric exclusion where you've only got 1 anastomosis that can potentially fail. So it's a bit of a I think it's just a call you need to make at the time. But a small laceration to D1 or D3, I just try closing it and putting a patch over it and just treating it almost like an ulcer. And then when it comes to injuries that involve the sphincter complex, realistically, like, call your best pancreas guy and get them to come and help you, because I mean, that patient's like looking at getting a trauma Whipple's, which I spoke to a couple of the pancreatic surgeons about this kind of thing, and I think between 3 of them, they've done 1 trauma Whipple's. It's not common at all. The other thing is you need to, you should try to just observe the full length of the duct. If you're in there doing a trauma laparoscopy, make sure that it doesn't look like there's a hematoma or any stranding around the duct, because you don't want to miss a distal pancreas injury that then leaks, and then you get all the problems associated with the pancreatic fistula. Ooh, I didn't realize that was still in there. Ignore the naming of that. We did have one patient, and this was the photo I showed earlier, where we had kind of an occult transection of the pancreas, and the surgeon involved in that, what he did was he essentially just divided the pancreas at that point, oversewed the end on the head side, the end of the duct on the head side, and then the patient was 17, and he said, if I take out all that pancreas, the patient will become diabetic. So he just essentially flipped that down and did a pancreatic ojejunostomy, so like you would do for a Whipple's procedure, but he left the head of the pancreas in, and the patient ended up doing really, really well, and they maintained their endocrine and exocrine function of the pancreas that way. So, like I've seen one case of that. All this stuff's very uncommon. And yeah, complications of pancreatic trauma, the same as for like doing pancreatic surgery. So shock, sepsis, pancreatitis, leaks, fistulas, and then insufficiency. I think that's it for the trauma talk. Do you guys, I mean, it was just all upper abdominal trauma, or I've got a lot of different trauma talks, but did you guys have any questions about that or anything else?
So I had a question.
Yeah.
Just regarding, like we say, grade 1 and 2 duodenal traumas, most of them can be managed conservatively. But like the grade 2 consists of laceration less than 50%. So if that laceration is there and the patient is hemodynamically stable, we would still go ahead with conservative management, knowing that
I think if it's a hematoma,
okay, so it's the
manage it.
Okay.
But if it's a laceration, like particularly if it's a full thickness laceration, you're going to have to deal with that.
Yeah. Just wanted to clarify that.
The hematoma is like I think all these almost any abdominal hematoma can probably be managed conservatively. You guys have any other questions?
No, Dr. Barry, I think that was a
okay. Well, I think I've got you guys again for another tutorial in a couple of weeks' time. Can't remember what I think it might be inflammatory bowel disease or something.
It is on Dr. Brad is doing inflammatory IBD, and then you have exam prep on 31st October.
Excellent. And I think I'm over there over in Fiji in mid-September with Glenn and Sonal to go through some stuff as well. So that was good. Like I think you guys are doing really well, and I think your knowledge is there. The only thing is just tightening up how you present it, but you guys have all the knowledge, so it's good.
Thank you, sir.
Righto. I'll see you guys later.
Thank you, sir.